I'm the Director of Health Policy at the CSG National Headquarters in Lexington, Kentucky. As always, when these webinars start, we've got a couple of housekeeping details to cover. You will be in listen-only mode if you've joined us this afternoon for the webinar. We'll ask that you type in questions in the GoToMeeting box on your screen at any time. We'll take questions at the end after all three of our speakers have had a chance to tell you about their experiences in oral health. And we'll get to as many of those questions as we have time for. The audio and the slides from today's webinar will be posted on the CSG Knowledge Center. That would be www.csg.org/KC. If you're listening today, you will also get an email notice of that linkage when it's up. It usually takes us a couple of days. And as well, if you're a subscriber or a recipient of our e-news articles, our e-news that goes out every Thursday, this webinar will be covered in the June 19th edition, also with a hot link to the Knowledge Center posting. Today's webinar will focus on oral health, the problems with access to care, particularly for children, and the opportunities that the Affordable Care Act presents to increase dental coverage for children and adults. We also have with us two speakers today from Maine who will talk about how that state approached its oral health access issues and passed legislation in the 2014 session. Our first speaker will be Shelley Geishan, who is Director of the Children's Dental Campaign at the Pew Charitable Trust in Washington, D.C. She leads Pew's work on improving children's access to dental care and overall oral health. She served on the Institute of Medicine panel that released a major report in 2011 on dental access problems. She has a master's degree in public policy from the University of California at Berkeley. After Shelley has presented some national context pieces, we'll move on to what's been going on in Maine. Our speakers there will be Representative Heather Siraki, who has served the residents of Maine's House District 128 since 2010. She has an Associate of Science degree in dental hygiene and currently works in the dental field. She's a member of the legislature's Health and Human Service Committee, and has also been appointed to the Substance Abuse Services Commission, the Advisory Committee on Dental Education, and Maine Children's Growth Council. Mike Saxel, also from Maine, has served in the Maine House of Representatives from 1995 to 2002. From 2001 to 2002, he served as Speaker of the House. Since leaving the House, he has been the managing principal of Main Street Solutions. That's Maine with an E there, Main Street Solutions. Mike and his team work both in Maine and the Northeast region and with clients throughout the U.S. They specialize in state government relations, procurement, grassroots and grass top communications, and press relations. He's a graduate of Maine's Bowdoin College and received his law degree at the University of Maine. So that's our panel today. Pretty exciting lineup of folks. Shelley, I want to start with you and ask us if you can tell us a little about the oral access problem in the country. Perhaps our listeners will remember the story of the 12-year-old boy in Baltimore who died in 2007 as a result of untreated tooth infection. It seemed to me it was sort of a call to action as we all read about that horrible story. Was that the impetus for Pew's work on oral health?
Thank you very much for inviting me for this. Can you hear me?
Yes.
Okay, good. If you need me to speak a little louder, just speak up. Certainly, Diamante Driver's death was one of the main drivers behind our work, but not the only one. Another one was that Pew had a sort of portfolio of children's programs at that point, and we also focused a lot and continue to focus a lot on ways that we can help states do a better job with the responsibilities that they that they have. And one of those responsibilities is to make sure that children enrolled in Medicaid and CHIP get access to dental care. And they've been falling down on the job. They've had a difficult time administering that benefit, and we thought that we could make a contribution. But basically what we found when we studied the issue and developed this initiative is that dental care is the biggest unmet health need in the country, not health care. It's dental care, both for adults and for children. Over 47 million Americans live in an area of the country where there's a shortage of dental care. That's 1 out of every 7 Americans. And by some estimates, it's actually worse than that. Dental caries is the #1 chronic disease among children, and yet over half of children enrolled in Medicaid didn't get any service at all in 2013. So our record, the need is really great, and the record is bad. So the only thing that Pew was completely convinced of in going into this work is that the status quo was not acceptable, and the current set of solutions that states were trying were not sufficient. So with respect to shortages of dental care, because I talked about how many Americans are without access, there's really several ways to look at that. One is that there's a geographic maldistribution of providers, but the other is that there's an overall shortage in most states, and there are very few dentists who actually accept Medicaid or CHIP, and very few who accept people who aren't largely healthy and who have private dental insurance or the ability to pay out of pocket. So if you're in an institution, or if you're in a low-income district, or if you're in a nursing home, if you're rural, if you're a minority, if you have language barriers, the private dental system does a great job with most healthy people who can pay, and that's most of America. That's probably 2/3. And with the other third, it really pretty much doesn't work. So we need new solutions. So access is a complex issue. There are many different factors, and one of them is insurance and the ability to pay. So one of the things I wanted to cover is talking a little bit about the ACA. But the slide you have in front of you now is the percentage of the population in each state that is underserved and living in a shortage area. So the way to read this, if you're quickly trying to find your state, is that the darker the color, the worse the shortages, in a nutshell. And even the lightest color, you've got about 5% of people who are in an underserved area and really have no hope of getting dental care. So our next slide shows what the framework is for the Affordable Care Act. And basically, the way most of you know the framework of it if you're in healthcare, but when the Supreme Court ruled that it was in fact they were going to uphold the validity of the law, they also said that states had the option to decide whether or not they were going to expand adults coverage to adults, and only 23 states have done that. And adult dental coverage is not an essential health benefit in the law. So basically, the dental issues for adults were pretty much left on the table and not resolved by Congress, which is really a terrible oversight. While our project focuses mostly on kids, the next frontier is clearly trying to make reforms for adults because they've been really left behind. For kids, however, the pediatric dental benefit that the law requires children to get may be either embedded in a medical plan or be available for purchase as a standalone plan. However, there are no requirements that families actually buy that coverage. So there are real loopholes. All of us, I think, in the advocacy community thought that the fact that the law required a pediatric dental benefits for all children meant that that issue was resolved, and it isn't. We're going to have to either work state to state, or we're going to have to work at the federal level to revise that law if ever that is possible. Why don't we go to the next slide? One of the things I think is important to talk about is what impact the Affordable Care Act will have on the number of people who actually have dental coverage. And what we've shown you here is that the American Dental Association has done some very interesting projections using both their in-house economist and research staff as well as an external firm. And they think that the ceiling is about 8 million children. I think it's a little higher than that. When we first looked at the shape of the law after it was passed a few years ago, we estimated that it would be about 5 million. And between those two are probably about what the reality is. The 8 million that the ADA predicts is sort of split between the number of children who will be added to Medicaid and the number who get coverage, including dental, through the exchanges or the marketplaces. So, and for adults, it's not in your slide, but I can just tell you, the Medicaid, what ADA forecast was that they estimate about 4.5 million more adults will receive coverage through Medicaid, but it may not be comprehensive coverage, and about 800,000 more adults are likely to get coverage through purchases that they make, subsidized or not, through the exchanges. So the next slide, let's go to that. What I think is important to discuss is that coverage only matters if you actually can use it to receive services. Coverage does not mean access. We have so many difficulties with access now that many of us have been concerned, both happy about the increases in coverage and also concerned that we're setting ourselves up for a real train wreck and that there are going to be millions more children in the system that already can't take care of the ones that are in. Okay, so let me just say that again because there was some interference on the line. Coverage doesn't necessarily translate into access. We need to make sure that there are enough providers out there that are willing and able and ready and located where children are. There are a number of other factors that we haven't discussed yet. The dentist population is both aging and shrinking relative to the population, and it's, as we said before, it's maldistributed. I think we have a slide. I'm not sure if we actually included it in here, but we have statistics which I'd be happy to share at some point with the audience about the percentage of dentists in each state who are within 5 or 10 years of retirement age, and in some states it's as high as 40%. So if you think that you're in the next 5 or 10 years going to lose 40% of your dentists, and yet you're going to have millions more people presenting for care, you can understand what I mean. Then, of course, the other issue is that there are a lot of dentists that don't accept any insurance at all. They just expect payment at the time of service, and then if you have insurance, you can file for it yourself. And in most states, somewhere between 10 and a maximum of about 30% of dentists, I believe, accept Medicaid, and some of them only in emergencies. So we do really have an issue here. So that leads me to the next slide, which is what is the sort of structure in thinking around Pew doing any work on the dental workforce. Our core belief basically is that children and adults who need care should receive it from dentists whenever possible, but we also understand, because of all the factors that we've mentioned, that it's not always going to be possible. So just as the same set of calculations have been made on the medical side, sometimes 20, 30, 40 years ago, so the same calculations are being made today in dental, which is what can we do? So we've talked about this in two different ways. One is that we think that states should expand the places, like the sites where dental care can occur. There need to be more ways that dentists can supervise providers so that they can extend their reach into other settings besides just the private dental office. And then the other is that states may need more types of workforce providers to expand the dental team. So we've thought about this in many ways. In the middle, with respect to the middle bullet there about expanding sites, I mean, one of the things that my colleagues work on is sealant programs. We also have a lot of work on prevention in general, including water fluoridation. But sealants are our sealant programs are fragmented and poorly funded, and one of the problems is state laws, which aren't evidence-based and make them more difficult to administer and more inefficient. So states need to look creatively at those to figure out more ways that they can get more care to people in more places. So why don't I stop there and see if you have any questions or want me to move on?
Yeah, that's given us a good overview of what some of the issues are in states, and it's allowed our listeners to even see a map and put their state in the perspective of what you've been talking about. I know that your third bullet there on new workforce models is part of what we're going to be talking about today. So tell us a little to set the groundwork for then what the Maine delegation is going to talk about later in the webinar.
Okay. Okay, so I have two things to say. One is let's go to the next slide. And I think I will give you just sort of a quick overview of the kinds of new providers that states are looking at, because more than a dozen are looking at new providers at this point. And Maine is the most recent one to adopt a new type of provider. In 2003, Alaska tribal land started training community health aides to become dental health aide therapists, or DHATs. They are trained about 2 years past high school, plus internships and supervised practice before they're sent out to treat people on their own. But that's been a successful effort around the world for almost 100 years, because that model started in New Zealand in the 1920s. But mid-level dental providers are similar to a nurse practitioner or a physician assistant on the medical side. They're taught to do basic and routine services. They don't do the most advanced ones. It's a very small set of services compared to what dentists are trained to do. But they're trained very, very thoroughly in those few services. And they work under supervision of a dentist in a clinic or in a private practice. In Minnesota, which passed its bill in 2009, they actually have two types. One is called a dental therapist, but it's a 4-year model, and another is an advanced dental therapist, and that is built on a dental hygiene degree and could take about 6 years to complete. And they have varying levels of supervision and slightly different sets of services that they're able to do. And then in California, there's a new and very exciting model called the virtual dental home, which is similar to some of the other, there's a couple other states that use something similar. And some of them are called sort of public health hygiene models. But the cool thing about the virtual dental home is that they use telehealth technology to connect hygienists with their supervising dentists who are off-site. And that's a way to expand services where dentists have not located and are not generally going to locate. They could go to schools, nursing homes, Head Start centers, basically community settings. And Dr. Paul Glassman from University of Pacific, who has spearheaded this model, basically estimated that the hygienists with a few extra services could probably take care of about 60% of children's needs in a school. If we were to deploy dental therapists, they could probably take care of about 80 or 90% of the services that children need, and the remainder they would have to refer out to a dentist. Let me go to the next slide and just say real briefly that Pew recently released the first of its 2 reports with case studies. The second one should be out not next week, but I believe the week after. I'm not getting my dates quite right, but I think it'll be the 18th or the 20th of June. And we looked at actual experiences in 5 different places where mid-level providers are being used. So I urge our listeners to go on the Pew website and try to find those. But basically, let's go to the next slide. I don't want to take too much time because I know we have 2 other speakers. What we wanted to know is, do these providers increase access to care for people who were previously underserved? And there's clear evidence that the answer is yes. Are they a good business proposition for the clinics and the private practice dentists who hire them, and there's clear evidence, yes. And how does that work? And basically, the answer is that dentists are performing more complex procedures that only they can do, that they often feel happier doing, and that are more lucrative. So that's the long and the short of it, and I will stop there.
Okay, thank you very much. Now we're going to turn and hear how Maine has handled this oral health access issue recently in their state. Representative Siraki, we've heard Shelley talk about the national issues and cite some national statistics. Can you tell us a little about the status of dental care in Maine?
Absolutely. Thank you for having me. I come from a dental hygiene background, so this is near and dear to my heart. And we have a number of barriers here in the state, but I don't think that our barriers are all that much different to many other states. Yes, maybe to the degree we definitely have a strong dental shortage here, but I think many other states experience a lot of the same barriers that we have here. While Maine is looked at as a really rural state with a small population, we do have service centers, so Portland, Bangor, some of the bigger cities that we have here have similar problems that maybe a Boston or New York even may have. So I was very interested in this idea of the dental hygiene therapist here in Maine because of my background as a hygienist, and I also was exposed when I was in college to one of my professors who had been involved with something called the Rotunda Project, which took place at Forsyth Dental School in Boston, where they trained dental hygiene students right alongside dental students to do basic restorations. And it was going too well, I guess so well, that the dental board in the state of Massachusetts, as I recall, was very much in favor of this, but then the Dental Association caught wind of it and shut the program down. And because one of my professors had been involved with the project, I had the opportunity, the experience, and the background to understand what was being proposed when Mike Saxel contacted me and said, hey, would you be interested in being involved with this? I immediately knew what he was talking about. And I said, wow, this is a great idea. I love this idea. And I grew up in rural Maine, so rural that, I mean, we lived 2 miles on a dirt road, no running water, no electricity. So I know rural Maine. And I now live and work near the airport in South Portland. So it's I've seen sort of both sides of Maine and the challenges that are faced trying to get access to dental care. Maine is one of those really big geography type states. So I think travel distance can be a barrier that maybe some other smaller states don't have. And I'll give you an example. One of the hygienists that I work with is from northern Maine. It's about a 6-hour and 15-minute ride to her house from where I work in southern Maine. And she had a nephew that called her and needed some help. He had some dental pain, and he had been making phone calls, but he could not find a provider. So she jumped in and tried to find him help, and she had trouble finding him a provider. Finally found one who would see him for one appointment, not establish him as a patient because they were too busy, and months and months wait to even get in. She did get him in on an emergency visit, only to discover at age 26 that his teeth were in such poor condition that he ended up with one molar. All of his other molars were extracted, and he could not establish as a patient. And it was a 2.5-hour drive one way for this visit. Then he had a toothache come up again, and it was on his remaining molar, and it was about a year later, and he called his Aunt Stella and said, I need your help again. She finally got him in. It was a 3-week wait. He couldn't take the pain any longer, went to the local emergency room, and was prescribed a painkiller, some Oxy, and some antibiotic, and sent out the door. They never looked in his mouth because most hospitals, at least in Maine anyway, don't have any dental staff, any dentists or any kind of dental professional on staff, even though that's apparently one of the #1 reasons that people do visit the emergency room. And he was sent on his way. He couldn't take the pain anymore, even with the oxy and the painkiller, so he went to the local hardware store, got a pair of pliers, boiled them on his stove, went out to his garage and pulled his last molar. And I think everyone can agree that that is just not acceptable. We do have a dental access problem, and we have a significant dental access problem. So a mid-level provider could really help with a lot of these practices that are just so, their schedules are so tight that they could ease up the dentist's time. And so I was convinced that this would be a really fantastic addition to a dental team. The demographic issue was addressed earlier. We have a number of dentists in their 80s still practicing. Now, I work in the dental field, and I know how hard it is on your neck, your shoulders, your back. I understand why dentists, most dentists that I know of anyway, do not practice 5 days a week. And they do it, I think, partly because it is so hard on your body. They need a little break. And if you're in your 80s and still practicing, you're not working 40-hour weeks. You're just physically not going to be able to do that. So you say, well, why do people in their 80s still practice? Well, they can't sell their practices. Oftentimes they've had them for sale for years, but they don't want to close their doors, because when they do, they lose all of those staff members lose their jobs. And a dental hygiene therapist can come in and at least provide a certain level of care for a very limited number of services, but they could definitely help serve a need in those rural areas and in the cities too, depending on the situation and where they're located. I think that the question to me was, what are some of the barriers? So I agree, demographics is definitely an issue. The size of our state is an issue. The number of providers is an issue, and the location of those providers is also an issue. When I talked to a gentleman who buys and sells dental practices, he said that, and I assumed that the reason a lot of dentists didn't want to move to rural parts of the state was because they couldn't make enough money to pay off their student loans. And he said, au contraire, that these dentists in the rural parts of the state actually make more money than dentists in the bigger cities because their practices are so busy. The problem is it's rural Maine. When these young dentists come out of school and they're looking for a place to set up their practice, and they go to a very rural part of the state, they look around and say, what do I do? Well, it's very rural. And if they want a little more hustle and bustle, they're not going to find it in a rural part of the state. So sometimes it is hard to encourage those providers to move to those areas. And part of our challenge here in Maine was trying to convince various people that I would talk to that, yes, these therapists would move to the rural parts of the state. Now, I can't guarantee that, but a lot of dental hygienists that are underemployed or unemployed are from those parts of the state. That's where their home was. That's where they grew up. So I do think that people will move to those areas. And the example was given that, well, when we established nurse practitioners here in Maine, the nurse practitioners didn't go to the rural parts of the state. They generally are in the service areas. And I would counter that that may be true, and that may happen with this too. But like the young man from northern Maine trying to find a place to go, he was willing to drive. He was willing to find his way someplace if they only had the hours, if they had a location for him to go to. So even though it may be a bit of a drive, in Maine, a lot of people in rural Maine are used to the drive. They just need a place they can go to even find a spot.
Representative Siraki, you've painted a very picturesque or a very dramatic picture of what's going on in Maine and some of the issues. Can you tell us, just give us a little outline of what your bill does in Maine?
Well, this particular bill, we did have some compromise with it, but what we ended up with is a registered dental hygienist who can go on for the training to become a therapist with a select number of procedures, and it's a 4-semester program. And I didn't want it to be a 2-year situation, so The students may take their courses consecutively through the summer so that it condenses the time, even though the same number of hours in clinical class hours and so forth would be required. But they can do a 2-year program, or they could do, like I said, the semesters closer in time so they wouldn't have to wait. And they may start the program with their associate's degree, but by the time they're done, they must have their bachelor's degree in dental hygiene and their 4 semesters of dental therapy. They must operate under direct supervision. And I discussed with our governor and various people that had some concerns about this proposal, that in the future it very well may be that we will be able to open it up and look at general supervision, but there was enough resistance or ambivalence about it that we couldn't quite get that hurdle. And I was disappointed with that, because I really think that some of the areas of high need are our supervised neglect in our nursing homes. I really would like to see that as a site, and of course our school settings. So it's basically where we ended up with the final product.
And can these are the new mid-level people, the therapists, can they practice in all of Maine, or are there certain? I think I had read that there were certain types of clinics or certain settings in which their practice would be?
So they can practice throughout the state of Maine. They're not limited to underserved areas in any way. They can practice in under direct supervision. They must be under the direct supervision of a dentist, or the dentist in the office. And so the only restriction we had regarding that was that they must have 50% of their patients be Maine care patients. And typically speaking, most of those practices are in rural Maine. And that was the idea. The governor actually strongly supported that. The original bill was 25%, and he insisted on the 50 because he was trying to encourage these types of therapists to go to the rural parts of the state. And I personally disagree with that, because I don't know how you know, what if someone only has 48%? So I just didn't like the limitation on it. I thought if a practice is opening up, even if they only have 5% of their patients Medicaid, at least it's 5%. So it's a beginning, because a lot of dentists are hesitant to, with the very low reimbursement rates that we have here in Maine, they're hesitant to open up into that population because of the reimbursement rates. And not only that, the Medicaid population has a reputation for not being good about keeping appointments and that kind of thing. So there is some hesitancy there too. Now, the young man I gave the example of was willing to pay cash out of pocket. He was not a Medicaid patient. He still couldn't get an appointment. So sometimes the barrier is literally just the lack of providers. And sometimes the barrier is cost, but I can tell you, myself having grown up in very rural Maine, very poor, that people make decisions. And I may be a little more on the conservative side than some of the listeners here, but I've seen people with their satellite dishes on their house and the snowmobiles in the yard and that kind of thing, and they prioritize their money differently. My family made sure we went and had our dental care, so we didn't have those extras. So it is somewhat of an educational thing, a value thing. Some populations value this more than others, and so that's another barrier. That's another challenge that we have, is to educate the children and the parents and the population as to why it's important to seek that dental care and make that a priority.
Mike, I'm going to switch over to you now. Can you tell us a little about how the coalition came together to pass this legislation in 2014, and what was different about the experience in 2014 when the legislation passed, as opposed to the year before when the legislation didn't pass? Mike Saxel?
Hi, sorry, I still had you on mute so you wouldn't hear me chewing gum and drinking water. First, I want to say thank you to Pew and CSG for elevating this issue and giving it its proper place, and Representative Siraki and her colleagues at the Maine legislature who championed an extraordinarily difficult issue. This is not simple stuff, but let me tell you, and the work I've done over the last 25 years in public health and public policy as an attorney, as a legislator, as a staffer, in politics straight up, I've never seen a public health issue where the answer is so obvious and yet so difficult to attain. In Maine, we took the long road here. As Representative Siraki painted the picture, our issue is extremely stark, and I'm sure it's the same in most of the states we're talking about, where there is an extraordinary need, and then whether it is because of cost or because of the number of dentists or because of geography or because of oral health literacy or because of, you can name 100 problems, but the barrier to access to care is huge and it has real implications. And the saliency of that issue goes throughout everybody in Maine, whether you are the most conservative person on the right to the most liberal person on the left. Our coalition that we built over the last 3.5 years reflects people in the faith community and in public health and in business, reflecting the entire spectrum of the state of Maine. We began the process with a facilitation with dental health providers and all these other populations that went for 8 months, where we really sorted out these issues. And at the end, we weren't able to take the step forward besides the fact that we agreed we wanted more information that we could agree to. So that coalition built, the first coalition included that huge, diverse group of folks that went after and did some real primary research in Maine to document that, yes, in fact, all of these anecdotes, and let me tell you, Heather's anecdote may seem gratuitous to some of you, but it is actually absolutely typical. So that we were able to take those anecdotes and demonstrate that, yes, 2/3 of Maine dentists are over the age of 50. And yes, 40% of them are going to retire in the next 5 years. And yes, 15 of 16 Maine counties were federally designated as shortage areas. And yes, 33% of kids in rural Maine didn't have access to a dentist, and the number got worse. And so we were able to demonstrate that through that. And so we built a coalition that included the Christian Civic League and the social justice group Maine Equal Justice Partners, which is the legal services equivalent of a lobbying arm. We included the Maine Hospital Association, who had a financial and a healthcare interest because they were seeing people come into their emergency rooms that weren't able to get definitive care, but only, as Heather said, antibiotics and painkillers. We included people like the Maine Children's Alliance and the Maine School Nurses Association, because they saw firsthand the impact of lack of dental care on a kid's fundamental development, on their self-esteem, on their missed school days, on their social interactions, and on their diet. And they saw, and it included physician groups like some of the primary care docs who saw the long-term implications of poor oral health status to diabetes, heart disease, and lifelong wellness. So we had this crazy broad coalition of folks. The thing we did over 2012, 2013, and 2014, this is probably the most important thing I can convey, is we didn't give up. That's the simple thing. It is an extraordinarily contentious issue because there's, I believe, a fundamental concern in organized dentistry that this is supposed to be adversarial and somehow this will hurt the practice of dentistry. and it is the proponent's belief that not only will this not hurt organized dentistry, but as a business matter, that it will make the practicing dentist or the clinic more money, and we believe we have uncontrovertible proof of that, that the care given to patients in 53 countries for the last 90 years is equal to, clinically equal to, or better than that provided by a dentist, and that it provides care in a location without barriers that increases access so that parties who do not currently receive care in Maine, 50% of kids in Maine, for example, don't have access to a dentist. Parties who don't traditionally have access to care are going to grow the pie of care. It's not going to compete with dentists. It's going to add value to those practices. And so that's the message we sold. The coalition was broad and diverse, and we were willing to stay toe-to-toe. And you know, I found in my tenure in politics that doing the right thing is good politics, and that doesn't matter about party, and it doesn't matter about geography. It matters about, you know, principle. And I think most legislators I've had a chance to work with around the country come to their jobs with the exact same approach, which is, hey, this seems just like it's right. The marketplace is broken. How can we make a marketplace fix here? And that's what Representative Siraki did, and she was an amazing champion. You would be lucky to have her come to your states to share her success story with you.
Well,
That's what I got for you.
Okay. First, I want to remind our listeners that if they have questions, they can type those into their GoToMeeting box, and we'll be able to ask your question directly to any of our speakers. And I guess I wanted some advice from Representative Siraki. Mike sort of dealt with it a little. If we've got people on the line who are listening and who have recognized that the situation in their state is not too different than that in Maine, what might be the first and second steps that you would recommend someone take who wants to address oral health access issues in their state?
I would say the best first step is, as Mike had said, to build a coalition. You need to have various people all engaged, and so you need someone who's able to go out and build that coalition and bring people together and to educate, because it takes a lot of explanation. You need to sit down with the legislators one-on-one is really the best way to do it. It takes a lot of time, but that's really the best way. And you need also to educate the governor of that state, because you need them on board as well. And so you have to bring a lot of varying different people together so that they can understand the scope and what's really happening. And it's a really it's complex. There are a lot of moving parts. There are a lot of various individuals involved and entities involved. Everything from if there's a dental school in your state to dentists and the concerns that they have, and the dental association, what their concerns are. And again, as Mike said, oftentimes it's portrayed as an adversarial thing. But it's not really. It shouldn't be adversarial so much as working together and augmenting a dental team. It's a new dental team member, and it's not trying to take business away from a dental office. It's trying to grow the business in a dental office, much in the same way that a nurse practitioner and physician's assistants are auxiliary team members that help benefit the overall medical team. This is a way to help the medical team, the dental team build. And we have in Maine some providers that some other states don't have. We have expanded function dental assistants, and they are dental assistants that are allowed to do the filling. They may not do the drilling or provide the anesthesia, but they can actually finish a restoration once the dentist has done the drilling portion. And we have independent practice hygienists who can set up their own practices on their own to do dental hygiene work. So Maine has a history of being open to the idea of different types of providers and different types of settings. And so I think that was helpful here. Depending on your state and how restrictive they are, it may help to look at states like Maine that have opened up access through increasing the market and having different types of providers.
You know, the one thing I would add to what Representative Siraki said that she may not have said out of a matter of modesty, but the first thing is having a coalition and knowing your facts, but the second thing, or simultaneously, you need to have well-educated, passionate champions. And in Maine, we had Representative Siraki, and we also have the Speaker of the House, Mark Eves, and they, between the two of them, the entire political spectrum fits in between the two of them, and I don't mean that in a critical way at all. I just mean they're very different. They have different constituencies in the legislature and different outlooks, and they came to this conclusion from different hopes and different goals to some small degree. But they were willing to set aside what are their traditional interests, where they had a lot of differences, to work together on this, and they were extraordinary as a team. So you need to have champions like Representative Siraki and Speaker Eves also to be successful.
I think it was a very good team effort, that's for sure. And some other barriers that other states may encounter similar to here that are very difficult, if not almost impossible, to get those votes if you're looking for votes in the legislature, are personal ones that are good to recognize and know about, but also acknowledge that there's some things you just can't change, so you work around them. And that would involve personal relationships. So for instance, certain legislators may have family members that work for the Dental Association or work for dentists that belong to your Board of Dental Education in your state. And there were certain, we had some we had some challenges there. But once you recognize that, sometimes you can bring people to the table too to sit down and talk. And we had a little trouble with that, getting some people willing to even sit down and talk. And it's helpful when people will communicate.
Okay, well that's what's going to be done in Maine now that we've learned about what you've done. Are there going to be studies done? Are you going to look at how successful this model has done so that there'll be, besides what Pew is doing, will there be some information about how it's going in Maine that other legislators and other states can look to?
Sure. Let me jump in on this. So the stage we're in right now is we're done studying. We've done a lot of studying in Maine. We're at implementation. The Board of Dental Examiners is charged through Representative Siraki and the Speaker's legislation to develop a rule to set up the curriculum for the educational program, to set up the licensure requirements, and to set up the exam and the oversight. And that should be done by a year from the passage. So we're hoping by June of next year, we will be completely done with that entire process, and we will be having our first class of dental therapists begin the process. So we can provide updates on their Board of Dental Examiners process. We can talk about in the future about the educational programs that are interested. We've had several conversations with some Maine-based and some non-Maine-based schools that are very interested in pursuing this. And we can talk a little bit about the regional interests too. In Maine, New Hampshire, and Vermont, and Connecticut are all really looking closely at this as well. So those are all happening right now.
Okay. We have a question from one person listening in to our webinar who apparently knows something about what's going on in Maine and has asked that now that there is a dental school open in the state, how will that contingent of students from Maine affect the situation on access, and what will be done in concert with the development of the hygiene therapist program?
Sure, that's a great question. So about a third, we have a new dental school in Maine, which I did a lot of work on as well. It's a fantastic new program based on the AT Stills model, for those of you who are dental geeks, in Arizona, with a heavy externship component meant to try to place dentists in underserved areas. There are a contingent of the school that are Maine-based students, and then there's a bunch from New England and then from around the country, of course, as well. The first class will graduate in 2017. Their fourth year will be the first year they go out and do externship rotations. And it should help us bend the trend on retirement, but it will not meet the existing need that we have in the state of Maine. So right now, especially in rural Maine, and especially amongst low-income people and non-mobile people, kids, veterans, seniors, we have a huge failure of access to care. And with 40% of dentists retiring in the next 5 years, that huge challenge in access is going to be compounded. The dental school is an extraordinarily important strategy to begin meeting that retirement trend to serve those people. And it's also a very cool opportunity to train dental therapists alongside of new dentists, because they can begin that process. It's not intuitive to everybody to work in a team setting, whether it's in healthcare or in oral health care. And so training our new dentists next to dental hygiene therapists will create an integrated team approach and an awareness and a cultural acceptance that is super fortuitous for us in Maine, and we hope we'll have a huge benefit.
Okay. We've got another question coming through, and that concerns Medicaid reimbursements. People who work in this field know that traditionally, and I think Shelley even mentioned it early on, traditionally the Medicaid reimbursements for dental services are lower than any other reimbursement from other insurers or private pay clients. Shelley, can you talk a little about Medicaid reimbursement rates and whether raising rates will help with the access issues?
Sure. That's a common question that people ask, because I think many people just assume that if we raised Medicaid reimbursement rates enough, wouldn't that fix the problem? And the answer is no. States that have tried it, some have done pretty well, but generally they've only done well for a while, and they've only done well if they both raised rates and they did a ton of other stuff, like make it easier for dentists to participate, change the enrollment forms, they do enabling services, reminder calls, transportation. They basically have to make, the state or the Medicaid managed care firm has to do a ton of work, and they have to sustain it over time. And it really, there are only a couple states who have made much of a difference. So generally the answer is yes, raising rates helps, but it only helps a little, and the effect erodes over time. So the thing about hiring a dental therapist or authorizing them in a state, or hiring other kinds of providers, because not all dentists even employ hygienists, is that they can do certain services more cheaply than dentists, and it's more economic. It makes it economical and economically feasible and even possibly profitable to accept Medicaid patients when much of the care is being provided by a lower cost provider, such as a hygienist or a dental hygiene therapist or a dental therapist. So there are many strategies that we have to employ to improve access. Some growth on Medicaid reimbursement rates would be fabulous, and most states do need to raise their rates, but in this economic environment, it's extremely hard to do. So what we have to do is try to do more with the revenue we do have and serve them more cost effectively. And other new providers are part of the answer.
If I
Okay,
may
and we have one.
I was just going to say, if I might jump in, in Maine, we did just establish a new dental coordinator at the state level, and that's brand new legislation. I'm not sure where they are in the process right now, but that was supposed to help statewide, helping connect people that have need to people so that they know where they can find, where they can get care. So I think that could also help, is to have sort of a unified, a person sort of at headquarters that can help guide patients to where they can seek care.
And the last question I had, it is very specific, and it's probably for you, Representative Siraki. In listening to the talk about moving from legislative language that addressed 25% Medicaid patients in a clinic to 50%, the question is, do you know how many dental offices or clinics already serve 50% Medicaid patients? I guess someone wants to know sort of how big the eligibility pool would be.
Well, I think because we have such a high percentage of our population on Medicaid, about 1 in 4 Mainers is on Medicaid, we have a large pool. As far as the number of actual dental offices that have that larger percentage of Medicaid patients in their practices, I don't have that number, but I do know that we have roughly 660 dentists in the state, and I think it's about 280 or so accept Medicaid patients to some degree or another. So about a third or third to half of the dentists in Maine accept Medicaid patients to some degree.
So let me just jump in there and just say that there's that's absolutely correct, but the number that are taking new Medicaid patients is 112, and that's the more generous number, not the conservative number from another survey. So so that's one thing, and the second thing is that 50% number that the question was about tracks not the dental practice, but it tracks the individual dental therapist. So their work mix, if they're working in a private dental setting, has to be 50% Maine care or underserved. If they're working for a clinic, a hospital, at a school setting, at a wherever else, in one of those other settings, in a public setting, those thresholds don't exist.
Okay, that gives some detail, I think, that helps us understand. I think at this time we'll close down the webinar. I want to thank each of you for participating, Shelley Geesham with Pew, and Representative Heather Siraki, a current legislator in Maine, and Mike Saxel, who has been a legislator and is still obviously involved in public policy issues in Maine. I thank you very much. I remind everyone that this webinar will be posted on our website, a full recording of it that you can refer your friends and relatives to. We'll also try and link you to some of the key pieces, like to link you to the legislation in Maine and to some of Pew's pieces that go along with this, as well as the slides that we saw today. Also to our listeners, our general listeners at CSG, we're always interested in hearing what you thought about our webinar and also what suggestions you have for new topics and speakers in the health issue, especially for my attention, but in general, what kinds of things you'd like us to cover that will help you with work in your own state. So I think at this point we're finished, and again, I thank the speakers very much. Thank you.